Haley, can you, so sunset clock tubes, what colors are they?
Normalized.
What colors? What are the colors of the sunset? So, for your sunset tubes or your clot tubes, these are going to be your red tubes, your gold tubes, your orange tubes, and your red TT, red tiger top tubes. You may not. And you probably won't. Orange tubes are expensive. But they are considered. They're RSTs, rapid serum tubes. So if there's a test that can only be drawn on serum and you need it done fast, they will do it in an orange tube. So what do these tubes have in them or not have in them? As far as additives go. Prop the door, please. What will your sunset tubes have in them? Or not have in them? As far as additives go. So they will either have no additive or a clot activator. At the end of the day, what are both going to yield or produce a clot? If it has no additive and you sit blood in a tube and let it sit for a while, what's going to happen to the blood? It's going to clot. A clot activator is just going to speed that process up. Same thing. But that's where, again, some people get confused because a clot activator is an additive, right? That means you can't use a tube with a clot activator, like an orange tube, as your discard tube for your light blue tube. Does that make sense? Okay. Somebody say it. Okay. Next, I call them grass tubes. Going along with like the earth theme we have. These are your green, light green. Some people refer to their light green as mint. What do these tubes have in them? They have some kind of heparin. I don't remember if you have to know this or not, but it's either got sodium heparin or lithium heparin. Both of them have some kind of heparin. What is heparin?
A blood thinner?
Lab terms. Blood thinner, heparin as a blood thinner, we say for medication. Heparin in lab terms, we call a Yep. Heparin, giving it to you as a medication, if you're ingesting it or injecting it, that is going to be a blood thinner. In lab terms, heparin is an anticoagulant. It's just, it does the same thing, just know the difference. So that said, those patients on patients with bipolar or other mood disorders, they may be on a medication called lithium. What kind of tube out of what we've talked about so far do you think we would not draw that in? Those patients who are on a medication called lithium, they have to have their labs drawn every so often. In one of your green tubes, either your light green or your dark green, it has lithium heparin as an additive. What would we not draw a lithium level in? Green. Why? It has one of the greens has lithium heparin as an additive. Very good. after your sunset, after your grass tubes, what's next? Gold is in your sunset tubes. We have green.
The lavender, the turquoise, the dark blue.
Is pink on that list? Okay. Sometimes you can, if it's not on the list, don't worry about it. The lavender sometimes looks pink. Lavender pink. What is the additive in the lavender tubes?
EDTA.
What kind of EDTA?
It's an anticoagulant.
The reason why I'm asking you this is because of a question that you may see about lavender tubes that will say K2E, K3E, So you can see there, and again, do I know that you'll have this question? No. Do I want you to at least have seen it? Yes. So, sometimes you will see those lavender tubes referred to as K2E or K3E. That's just how you abbreviate the EDTA piece. EDTA, all that is a salt preservative. EDTA is just a salt preservative. The goal of the EDTA is to preserve the blood cells. Why is that important in lavender tubes? Why is preserving the blood cells in lavender tubes important? Yep. So, EDTA. Since the K2, K3 was a hot topic, I would write it down. If it's too much, don't do it. Don't matter. I will write it down here. K2E, K3. And then what comes after lavender? Gray. And we talked about the additive. Oh, so sodium, potassium chloride. And what is our gray tube mostly used for? Glucose. It's good at preserving glucose for a long time. Glucose for extended periods. So, if I have a diabetic patient, or if I have a patient who coded in the hospital, excuse me, and I needed to see what their glucose was, but the lab couldn't, whatever, the lab's backed up and couldn't run the level for a while. The gray tube can preserve the actual glucose in blood for 3 to 5 days. What does your book say? I think it's up to 5 days. Something like that. So, and then after your grade, does it list anything else? Nope. Okay. Then, all other tubes or follow facility protocol. Dark blue, mineral levels. It's royal blue.
Especially the fine glass, that's all.
So don't get caught up on tubes that aren't in your order of draw. you probably won't deal with them much, and after the order of draw is done, most facilities don't really have like a specified order of draw for after these. These are your most common blood tests that are going to be ordered frequently, and if you follow the order of draw for these, your lab results will be accurate. So everything else we're testing for, if you do, let's say there's a black tube and an orange purple tube, I don't know, whatever. If you mix the black and the orange purple tube up, or vice versa, whichever one you draw first, is not going to impact the integrity of the test. The order of draw list, if you draw them out of order, it will impact the integrity of the test. The one thing I wanted to show you, again, just to help kind of bring things in. So we talked about specific additives like EDTA and oxalate, or sodium chloride, potassium, blah, blah, blah. We talked about all that, right?
Yeah.
What makes this easier is this is an anticoag. 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 No additive. So every tube in your order of draw, except for your sunset tubes, has an anticoagulant in it. If your, so specifically for your sunset tubes, your red, gold, red tiger top, or orange, those tubes, you will find a what in them? If you find a clot, what is that? If there's a clot in the tube, what portion of the tube, the blood within the tube, what is going to be tested on? Let me reword it because it wasn't a good question. If we draw blood in a clot tube, or a sunset tube, what portion, what product of that
Serum?
tube
Yeah.
are we testing on? Serum. Testing on serum. What is the difference between serum and plasma? The components? There's one difference.
Serum has the clotting factor, is it fibrinogen?
Fibrin. Plasma has fibrin. So we generally write, or what I write is a line sentence to help me remember. Serum equals plasma minus fibrin. This equation that I wrote tells me that serum is plasma, but serum doesn't have fibrin in it. Why? Because in a clot tube, fibrin and fibers weave together, right? In a clot tube, fibrin causes the clot. So, if fibrin causes the clot, that fibrin is going to be at the bottom of the tube in that blood clot that you find in the tube. since your, other tubes that have an anticoagulant in them, they're not going to clot, the fibrin is still going to be all mixed up. It's still going to be in the components of blood, because there's no clot. Fibrin is what holds that clot together in a Sunset tube. And if it's holding the clot together, can we do anything from a testing perspective in lab with that clot? No. Does that make sense?
Yeah.
Can I explain anything differently? That's what I'm here for. Okay, good to move on?
Mm-hmm.
Are you moving on like to, okay, you need to on that one.
There was,
We get the ranges?
yeah, I have to look them up.
Never mind, I do it.
The grass tubes, what test would you use them on? Like lavenders versus.
Oh, yeah, that's a good point. So what test would you run for each?
Yeah, just like for my notes and trying.
I think that's a great question. Let's do all of them. We won't take long, okay. And in fact, like I said, you're probably going to be, I know you'll be tested on a CBC, for sure. So, blood cultures, what are we testing? So we're testing for bacteremia or septicemia. Light blue, clotting. Sunset tubes, we're testing things found in serum. For your graphs, we're testing things found in plasma. For lavender, hematology. Gray, glucose. So when I say serum, let's start with plasma. Plasma is 90% water, 10% what? Plasma is 90% water, 10% hormones, antibodies, glucose, gases, proteins. So if you know that, what are you starting
Just, I was working high school.
That's better.
What is that?
Oh, hormones. So hormones, if you know what it contains, again, because I can't give you exactly, I don't know exactly what the test is, what your test question will be. The goal is to say, if you know what's in serum, you can get an idea as to what kind of, if they say you wanna test a TSH, what color tube could it go into? Well, TSH is what?
Hematology, so lavender?
No.
We're going.
What is TSH?
Oh, it's a hormone.
It is a hormone. I can't hear. You have to speak loud. It is a hormone. So if plasma is 10% blah, blah, and we'll say fibrin
It's
as
a
well.
green tube.
So serum is the same thing without fibrin. So if your test question says TSH, what color tube TSH, what color two?
Green.
Why did you say red, gray? No, neither do I. One eye. Cause it's like Laneige, the skincare. Yeah, that's how I remember. So, you said, it's a good one, you get good skincare. That said, why did you say red? Very good. But are hormones also found here? Under plasma? So what are your answers?
It's green and red.
Green or red? A CBC. Lavender gray.
Lavender.
So, when I put hematology by lavender, hematology, think of what a hematologist does. They specialize in blood. That's red blood cells, white blood cells, platelets. That's their specialty. Anemias, iron deficiencies, so on and so forth. So if a test question is related to something about blood itself, like a complete blood count, that is going to go into a lavender tube. If you think about what is, what's on a red blood cell, what do red blood cells carry? What's attached to our red blood cells? Oxygen. What else attaches to red blood cells? There's more of this in diabetic patients.
Sugar.
Glucose.
Oh, glucose.
So what color tube would an A1C?
Gray.
Somebody said gray. Gray is a good guess, but an A1C is an average blood glucose over 90 days or 3 months, right? A gray tube is only going to give you the instant number of glucose.
Is it purple? I mean, lavender?
Yes. Why?
It's blood. It's regular. You want what the blood is doing.
Because what attaches
Four
to
words.
red blood cells?
Yeah.
Glucose. So what is the A1C measuring?
Over
How many glucose molecules have attached to that red blood cell over time? That's what gives us our answer, but it has to have a red blood cell. That's the correct, thank you. Does that make sense? Most common size needles.
25.
PLB is how I abbreviate the bottom. The most common, not what you see in practice. And
Is it range or just?
there's two numbers, 22 is one of them. 21 gauge, or I should say and 22. That is going, that I would assume that would likely also be a question. Why? Because most people generally are going to have okay veins. Again, depending on what your office is, where you're at. Why does the needle gauge size matter so much when it comes to labs? So, what are the most common needle gauges? 21 gauge and 22 gauge. Why? Because those are the two gauges that are less likely to cause hemolysis. Make sense?
Yeah.
What is syncope? Fainting.
That's how you say it.
What about syncope? Syncope.
Yep.
So syncope is fainting. It is common, or I won't say it, it's not uncommon when you're drawing blood. What can we do to decrease the risk of syncope in phlebotomy?
Ask them if they pass out.
Does that decrease the risk?
No, but it'll decrease the likelihood of me walking into it.
Mm-mm.
Stem of the question.
You're supposed to sit it down.
So they should be sitting down, yes. What? Oh, semi-fowlers, yeah. So you can lay down. Most of the time you're not. They're gonna be sitting in a chair. Feet flat on the floor. Their back. It's kind of the same rules for an appropriate blood pressure. Back to be supported. So they need to have some kind of back support so that their feet can sit flat on the floor. Walk the patient through the steps. And reminding patient to breathe. If a patient starts to faint, signs and symptoms of syncope, what are they? So pallor, or pale color skin. What else?
Would it be sweating?
Diaphoresis. Or excess sweating. What else? Pain.
If they faint, I'm gonna faint.
I don't feel good. And, cold skin. So these are signs and symptoms that your patient is going to have a syncopal event. If you notice these signs and symptoms, what should you immediately do? Stop and notify the provider. What would you do you leave the patient to go get the provider? No, you stay with the patient. What are you doing when you're staying with the patient?
Making sure they don't hurt themselves.
What is the number one priority for, they're sitting in a phlebotomy chair, the arm is down, so if they fall forward, can't get hurt. Most of the time they're back up to a wall, so they can't really bang their head. So they're not gonna fall on the floor most of the time. Let's say they're going into a syncopal episode, you've retracted the needle, you've engaged the safety. What is your priority in keeping the patient safe? The arm is already down, you're not changing it.
Is it to prevent injury?
Where?
The site?
Well, we've already removed the needle. Head. Hold or protect their head. Because sometimes a syncopal event can look like a seizure, and sometimes a syncopal event can turn into a seizure. So if that happens, what is the patient doing? And banging their head against the wall. We don't want a traumatic brain injury because the patient has syncopal event. Protect head. Elevate the feet, if able. Why do we elevate the feet? That excess blood we have in our legs, we're pushing it back up to our core so that it can be sent to our brain. Cold packs on the neck, or behind the neck. And then, once the patient is fully conscious and they say, I feel better, and they can sit up, you can give that, again, check with your facility, something sweet to drink, like apple juice or orange juice. Because most of the time, even if they're not diabetic, after a sink flow event, the sugar goes way down. So if you bump their sugar back up past the sink flow better. And then get a set of vitals. Notify the provider. Any other questions with lab stuff?
Okay, this is really, okay, my hair is down, but the yellow, the blood cultures, is that the yellow?
Yeah.
Okay.
Okay, let's talk about EKGs, and I will go back and clarify that with you both. Everybody's favorite thing. You have to know placement.
Placement was all the way different.
And I would guarantee you that you'll answer no to this, but did the MAs that you watched, did they touch and feel the ribs?
No.
And they were not placed correctly. So, if you've ever had an EKG and you did not feel the EKG technician pressing in on your chest, the lead placement was probably not correct. So, you have right arm, left leg, right leg. And then you have your precordial leads. These are precordial, is just another big word for chest leads. And they go in order, like you read a book, left to right. You have V1, V2, V3, V4, V5, V6. This is how I remember how to place them. You can do whatever you want. V1, this is how I write it first off. Sternum to the right sternum, left, armpit, collar. So this is how I start my list, because I would almost guarantee, again, you're probably going to have questions about where you place these. What does an MA do on their day-to-day journey? In a busy internal medicine clinic. Injections, EKGs, all the fun stuff. So, now that I have my idea as to where I'm at, now I'm going to place the ribs. So, my V1 and V2 are the third intercostal space, right? You're right, fourth intercostal space. Fourth ICS. And V3 through V6 is where? Fifth intercostal space. So now, that's how I break it down. Fourth intercostal space, fifth intercostal space. Break it down a little bit more. V3, some textbooks will say between V2 and V4. Some textbooks say on the fifth rib. What does your textbook say?
Between 2 and 4.
V4 collarbone, so that is fifth rib or fifth intercostal space, mid clavicular. So if you take the collarbone, it starts here and goes here, and you cut it in half, like if you draw a fake line, should go halfway in between, that's where V4 should go. V5, so it's gotta be halfway between the collarbone, it's gonna be on the fifth rib, between the collarbone, between the armpit, in front of the armpit a little bit. So fifth intercostal space, anterior, axillary. And V6 is lined up with the armpit. So it's fifth ICS, mid axillary line. Right arm, placed where? Right. Left arm, left leg,
I mean,
left leg, right leg, right leg, right? Those are super simple. You shouldn't miss those. That said, artifacts. There are three main artifacts you'll be tested on. A wandering baseline, 60 cycle,
Which one is that one? 'Cause
AC interference.
Isn't it with like the electronics?
It's under
Electronics.
elect.
Electronics,
No,
electrical.
when you, okay.
So, a somatic tremor,
wait, we have, what
It
about?
interrupts all the time.
Yeah, we just had a question about it.
Yeah, and I
Mhm.
missed it.
what was the question?
It showed us the EKG
Doesn't
thing,
have to be exact.
and it was asking, what is this showing? Like, is it showing wandering, interrupted, somatic tremor?
And it said he was interrupted?
Yeah, it was.
What did it, can you draw it?
It was like, it was the
No, I'm
signal
not
with the
looking
break
for-
in it. It was the signal, nothing, and then,
Oh,
or,
okay.
you know, it will continue elsewhere on the thing, yeah.
So
Yeah,
It
interrupted,
showed, it had a picture,
It had a
and it was
picture,
showing,
but
it
it-
said, what is this EKG
My
showing?
question was like, what artifact happens like when the electrodes fall off or?
Yeah.
That was mine, but it was still interrupted.
The one y'all talking about, I
No,
think.
like, how I had it was like.
Oh, yeah, yeah.
so listen up. So here's where this can get a little bit confusing, where you do have to read the questions a little bit. Because artifact can be caused by patient movement. Which one of these, 4 artifacts can you say are caused by patient movement?
Somatic muscle.
Wandering baseline, interrupted, right? So read the question and see what it's asking. So a somatic tremor is going to look like this. You have your normal, that's your somatic tremor. It is a very quick, kind of like little blip. This, in my brain, or I should say the way I explain it, is this is a, because remember how long a 12 lead EKG, how long is that? How long is a 6 second, or how long is a 12 lead EKG? It's one sheet of paper, but it's taking a picture of the electrical activity of the heart for how long? It's more than 6 seconds. 10 seconds. So it's a 10-second picture of the heart's electrical activity, right? If you see a little bit, in that whole sheet, you see a little bitty line that looks like this craziness right here, just a tiny little bit, that is a somatic tremor. These are going to be things like you can say a sneeze, you can say a tremor, like a Parkinson's tremor. Yep. Or a cold chill. So this is a very brief, quick little blip that something happened to the patient, right? So if I'm lying down and I'm having an EKG done and I get a cold chill, I go, that's going to show up on the EKG like that. Did it last 10 seconds? No, it was probably less than 1 total second, right? That is considered a somatic tremor. Can you see it consistently? Yes, because if a patient has a Parkinson's tremor, it's going to be consistent like that. So, depending on what they will generally tell you the cause. If the patient sneezed, don't keep that one. Do it again when, run another one where they're not sneezing. If they get a cold chill, what should you do? Give them a blanket. Now, if they have a Parkinson's tremor,
Something you could do.
There's nothing you can do.
They say
You
you're
can-
supposed to put the hands under
They
the
can-
buttocks, yeah.
They can, I think the correct answer that doesn't really work is they're going to want you to try and immobilize the arm that has the tremor, or immobilize whatever part of the body that has the tremor. You could try that. It's still there, but yes, you should try. A wandering baseline, I call it the roller coaster. The baseline, it looks like this. It looks like a patient breathing. You can still read the EKG. The baseline is what your spikes and valleys come off of, right? That's your baseline on an EKG. In a wandering baseline, it looks like a roller coaster. It dips in and out. Most of the time, yes, it's caused by patient movement, specifically breathing. So if you watch, especially if you put the leads on the belly, if you put the leads on the bottom of the belly, at the bottom of the abdomen, bariatric patients, or even if we're lying down, what moves when we breathe? Your stomach. So if you watch this, and you take a breath in, right? That's your wandering baseline. How could you get rid of that? Place them in a different position. Can they hold their breath?
It happens so fast, they don't know.
Also, is your patient gonna die because they held their breath too long?
No.
No breathing.
Right. No, they, cause their brain is gonna tell them to breathe.
What's more,
Oh, I'm shocked, like, what?
What's-
I'm sorry, would you please come up with like somebody that struggles with their weight or?
it can be anything. It's dependent upon the placement of the leads.
So the most important placement is the precordial leads, basically, cause they be putting in others anyway.
That is not correct.
Mm.
That is, so here's the thing, and I get it, because in school, I too had a big issue because they teach us something, and then this was in my undergrad, they teach us something in school by textbook, we'd go watch in the hospital, yeah, we really want to do it. Well, why were we taught that? Because that's the textbook way to do it, that's how you should be doing it. Why do we have so many safety issues and errors in the medical field? So, 60 cycle interference is going to look like this. Continuous. I call it the 3 B's. A thick, black, bold baseline. A thick, black, bold baseline. Let me turn it up. It looks like this. It is a thick, black, bold baseline. Your baseline should look like this up here, this line. It should be a straight, thin line, right? With a 60 cycle interference or an AC interference, that means there's some kind of electrical interference. Either the outlet is not grounded appropriately, there could be a frayed wire to where you're plugging the EKG in. Sometimes fluorescent lights emit electricity and the EKG is really sensitive and it can pick it up. If you have another EKG that somebody's doing next door, it can pick up the electrical interference from them. Sometimes if a patient has a cell phone, I've seen smart glasses, I've seen the smart watches, I've seen the smart rings, all of that stuff, that can cause a 60 cycle interference. If you see this, how should you get rid of it? What would you do to get rid of it? Ask the patient if they have smart something on. Remove their cell phone, remove their smart glasses, remove their watches. I also will have them take metal off. Metal is a good conductor of electricity, right? Sometimes that will also fix it. You may need to switch to a different outlet. You may need to turn the lights off. Just get rid of electricity. That's the goal. Interrupted. So interrupted is going to look like this. this what it kinda showed you? Where,
It kind of.
I think the picture cause I had a picture with the first sentence, it was like a line up here, and then it went down a little bit, and then it was like another line, it was like a gap, it was like a step, basically.
Right, yeah, versus I. Yes.
That's all it was.
here,
That was like the narrative.
So- interrupted means that the recording is interrupted, right? If you interrupt something, if somebody comes in to interrupt my class has stopped for a minute, right? If my baseline or my EKG is interrupted, I have stopped recording for a period of time. So you're not going to see anything. What do you think you would see, or what do you think is a cause of an interrupted EKG?
The electrodes being lifted off.
A lead falls off, a lead is broken, it's not picking up, lotion, it's not attached well to the skin. At the end of the day, interrupted means it has stopped recording for a period of time. Again, what can it be due to? Probably some of the same things like a somatic tremor. If a somatic tremor is so bad and you put the lead on the patient's right arm, can they flip it off with the tremor? Yes. So use context of your question. But if it's interrupted, there is a gap in the actual EKG.
Can you hold it down?
No. What do you emit? What should you do? Oh, and that, I wanna say that's probably a question.
I was asked because
You saw it?
that's what they told me to do. They're like,
Oh,
and
no.
it doesn't stay, just hold it.
No.
Dear Lord have mercy.
That's why I started, I'm like,
What y'all?
So if you have, so prep your skin, right? So your skin should be shaved if the person is really hairy. You should have gone over the area with an alcohol swab. This is what I do. You don't necessarily have to do it. If they're really hairy, I shave the hair. I go over the area with an alcohol swab. I rough up the area with a piece of gauze and make sure that that alcohol is dry. And then I place the lead and push down. That makes it stick. Now, if a patient is diaphoretic, or they have tons of lotion on, I can't get through the layers or whatever, then I'm going to bring in a transport or medical tape to tape it down. That does not interfere with your EKG. Holding it, yes.
Yeah, he was so hairy that she just put it right on.
yeah, she said, I'm not gonna shave you because the last person I shaved, I need.
Oh, sweet Lord.
Okay.
She said what?
She was gonna shave him because the last person she said shave, she mixed it him, and he wouldn't stop with it.
There are, what other questions have you been asked about EKGs?
Now, can we do the, what is it, the link, when it asks how much, like, was it 5, 10, 25?
Yeah, we had a question like that, it showed us an EKG and it was like, what length is it showing? Or something.
Yeah.
What standard, yeah, that
What
stuff.
length?
The time,
The standard is standardization. The question
Oh.
the answer was 10, isn't it?
No, cause I clicked 10 and I got.
Well, maybe it's two different ones, cause I don't remember.
I got 10, I got it right.
I can't remember.
So again, with any test that you do, point of care testing, EKG testing, there has to be some quality control, right? What is the quality control of the EKG? That calibration or standardization. That calibration, I have a picture of one.
Oh, so this is kind of like, supposed to be a confusing question, but an easy question.
Yeah, it's pretty easy.
Would you show me this EKG?
The question about word.
I'm not.
Yeah.
We do
Maybe
this
some
for
of
the
us see them
summer.
like, I just, I mean.
I already tested it.
It's that they don't take it too
That's a
long.
no.
Oh, yeah.
Shit, I don't care. I'll stay a little longer.
This right here.
There's a five.
There's not
Yeah.
Listen up, please.
Five is the,
That's at the bottom.
Right here, right here, right
You
here,
don't need it.
yeah, that's.
right here.
Yeah.
What are these? These are called your calibration, or these are known. These let you know the EKG machine has calibrated itself and it's working. What is it actually called? It is called a standardization. In order for you to say that you have an accurate, quality EKG, your standardization should be 10 millimeters tall. How do you know that? And this is very blurry, but this is a big box, this is another big box. Every big box has 5 small boxes across, 5 small boxes vertical, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Each one of these dots is 1 millimeter, so that's 10 millimeters. So let's go over to our standardization. So it looks like it starts here, ends here. Oop. I count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That lets you know that your EKG has performed its internal quality check and it's good to go. Questions about that? What else have you been asked about EKGs?
That was it.
That, yeah.
It's
It's
just like
just
minimal.
Well, and then.
Colors. The colors. The colors. What colors?
Remember the first EKG?
For colors,
Even though apparently in some places, I don't know, cause I haven't actually done one yet, but the leads are in order.
they are.
Other
They have
things.
lead. So your EKG leads they do have colors. I don't memorize them by colors. I remember
Okay.
V1, V2, V3, V4, V5. Where colors come into play is a telemetry monitor.
Okay, so we don't need to know that.
I don't remember, but it's easy. So this is how, okay, for a 5-lead tele placement, or sometimes they'll also do this for Holter monitors. You're going to say white on right, clouds over grass, smoke over fire,
Mm-hmm.
chocolate in my heart. What do I mean by that? Is white on right. White is the color of clouds. Are they not?
Yeah.
Grass, green is grass. Smoke, black, smoke, red, fire, brown, chocolate. White on right, clouds over grass, and then you move to the patient's left side, smoke over fire, chocolate in my heart. Chocolate is placed at V1. So brown or your chocolate lead is V1. Sometimes I'll do V2, it just depends. White is the right arm. Green is the right leg. Black is the left arm. Red is the right leg. Left leg, sorry. White on right, clouds over grass, smoke over fire, chocolate in my heart. So with a 5-lead telemetry pack, you just have to know V1. Where does it go? It's placed at V1, just like a 12-lead EKG. It's at the fourth intercostal space, right of the sternal border.
They have a weight with muscle.
Yep. Any other questions? I know this is the patient care portion, so we'll just kind of spitball because I know you don't know this. If you for blood pressure, if you use too big of a cuff, what kind of number will you get?
Low.
False low. If you use too small of a cuff, what kind of number will you get?
False high.
Excuse me. If a patient is rude or yelling or loud, whatever, what should you do?
Let
You should listen, but
Talk to the injured.
yes, but let's say that they're out in the waiting room.
Put them in the front.
Yeah, separate them.
What? So that said, oh, for a blood pressure, how long should a patient be sitting down?
5 minutes.
And what arm is best?
Whichever one. That doesn't have blood drawn or
We try to
mastectomy.
go, we try to use our first choice is the left arm. Why? It's closest to the heart. What are some reasons why we would not be able to use the left arm?
Mastectomy.
Shunt, not a pacemaker.
A mastectomy.
Pacemaker's gonna be in the chest.
A mastectomy.
Can it recently
So why could you not do a blood pressure in the left arm? A left-sided mastectomy, an AV shunt, an AV fistula.
Amputation.
If they don't have a left arm, then you do it where?
Right.
In the right arm.
That's crazy. Everyone doing
You should do the left.
They do whichever one is closest to the machine. That's the shunt graft. So most patients will tell you, but you should also say, do you have can I take your blood pressure in either arm? And you should be taking it in the left arm, it's most accurate. What is the top number called? What's the bottom number? And how should the patient's feet be? Well,
I had a patient who was
Flat apart?
Get used to saying, uncross your feet, uncross your feet, uncross your feet. You'll say it
All day long.
I say it's all
Listen up, I can't hear.
How is the arm supposed to be rotated?
Your arm is supposed to be level apart.
Yeah, so she hold them.
Yeah, she put it under her
Yeah.
ankle. Okay, that makes sense. She put it under her arm and take it.
If your arm, so your arm that you're taking your blood pressure with should be level to your heart. So generally I take an arm, well, my patients are lying in the bed most of the time. But if the patient is sitting up, you should be holding their arm, generally like at your waist, I would say above your waist somewhere. If you hold it higher, you get a false low number. If you hold it lower, let it dangle, false high. Let's use the rest of the time to get signed up for your NHA.